All right. Good evening. My name is Salvatore Seeley. I am Health and Wellness Program Director at Camp Rehoboth. I'm so excited and glad that you could be with us this evening for one of our live programs. And tech stuff, I think we're all Zoombies by now. That's what I've been calling myself and other people that are on Zoom all the time. You know how Zoom works, and if you don't, I can give you a quick tutorial. On the bottom, there is a box that says chat. Please feel free to send me a chat if you're having any issues or any concerns. And the great thing about this is we're not doing video except for Dr. Bill and I. But please feel free to send us a question. There's a Q&A button on the bottom. So down here, Q&A, just click on that. You can type in some questions. We've been collecting questions all week through Camp Rehoboth and through social media. So we can definitely answer questions that come up for you if we're not able to get to that. So let us get started this evening. I wanted to, again, thank you, and I wanted to introduce you to the most important person in my hour this evening, who's been such an instrumental part in HIV care and infectious disease care here in Sussex County. And I've really got to know Dr. Bill, and I'll give you a little bit of background about him. And he's been such a great blessing for our community. So we're really honored to have him this evening to have a very informal discussion about the vaccines that are available for COVID. So Dr. William Chasanov, DO, is board certified in internal medicine and infectious disease. He serves as the director of clinical transformation at Beebe Healthcare. He also sees patients in hospital at the Margaret H. Rollins Lewis campus and at Beebe Infectious Disease and Travel Medicine. He received his medical degree in 2007 and completed his internal medicine residency at Christianacare Health System in 2010. He received his MBA from University of Delaware in 2011. Dr. Bill completed an infectious disease fellowship at Cooper University Hospital in Camden, New Jersey in 2015. He is the COVID-19 medical response doctor, and he is employed by Beebe Medical Group and is a member of Beebe Healthcare's medical staff. Dr. Bill, if you want to come online, that would be great. Hey, there you are.
Thanks, Sal.
Yeah.
I didn't know you knew that much about me.
Well, it doesn't. The internet is wonderful and tells us all sorts of fun and sordid things.
Well,
But thank you again for spending your time with us this evening. I know this past year has probably just been a whirlpool for you, and especially now that the vaccines are being distributed, I know you've been probably being kept busy 24/7, right?
It's definitely been a busy year, my friend. I will say that.
Well, again, thank you for spending some time. And if we can, why don't we jump into a conversation, maybe a little brief thing about COVID. We've had lots of questions from community members about how different people get different reactions when they get infected. I know this doesn't have to do with the vaccine, but this has been a question that we've been getting a lot. Why do some people get really sick? And then why do some people hardly get symptoms?
It's an amazing question that we don't really know the full answers to. And I think that the reason for that is because there's a lot of factors that probably lead to that question. You know, it's even interesting to see, I'll even add another dimension of confusion to that question, is that back in the spring of 2020, when COVID-19 was first in our area, we saw a significantly higher amount of sick people than what we saw during this most recent surge. And just to kind of level set us all, that in April and May of 2020 is when in Sussex County we saw our first surge of COVID-19. And by the fall, in the early winter, our numbers had significantly dropped. Never went away, but significantly dropped, at least of those that we knew who were infected in our community. Around Thanksgiving, as expected, things started to, or about a week or two after Thanksgiving, things started to increase again, followed by Christmas and New Year's. And now we actually had, and we being the state of Delaware, had a worse surge than we did in April and May of 2020 that we're luckily coming out of now, or what at least appears that we're coming out of. So when people back in April and May, we had a lot of people who were extremely, extremely sick. And I am not saying we did not have extremely sick people during this surge, but people definitely appeared to respond differently. I think part of the reason for that is because we were still trying to identify which treatments would be the most helpful. What processes would be the most helpful. If you remember, and again, I know that I'm clinical and I'm medical, but bear with me here. We were told best practices back in the spring of 2020 was when somebody became so ill that they ended up having a breathing tube put in, sometimes a little earlier than we would have put a breathing tube in for other reasons. We stopped doing that shortly after because we found that, you know, we could manage these patients with COVID that were severely ill, not always with a breathing tube in there. We scoured the literature and we found that steroids had a role in the treatment of this to at least decrease the inflammatory response that some of these people were having that were leaving them critically ill. So we use steroids, which, you know, at the beginning we were told that we need to think twice about using. We, and I'm very happy to say we as in Beebe Healthcare, we're the first hospital in Delaware to use convalescent plasma that was obtained from recovered patients that ideally had antibodies against the COVID virus that we could then use with obviously someone's permission to infuse them with these antibodies to hopefully decrease the severity of their illness. Then we ended up having a medication that came out called remdesivir that again probably does not have as much activity as initially thought, but does still have some activity and has benefit in the right amount in the right person. So all these things that we didn't have at the very beginning, we then started to have, which may make people less sick, or at least give the appearance that people are less sick. The other part of this is that this virus acts differently to people and their immune systems. As a general response, as we all move through life, that's what I say, getting older, this virus tends to have a lot more problems the older that we are. And in the initial wave, we saw that it really hit those who were much older. So in the 70s, 80s, 90s, not saying those people are old, they're just much older than those who seem to be infected in that second wave, which tended to be in the 20s, 30s, and 40s. So there was also a demographic shift in the age that could make it seem why some people were sicker than others. So back to probably my original statement is that the virus just acts differently depending on you as an individual. So Sal, I may get extremely sick, but you may be almost asymptomatic and not have many symptoms at all. And it's just because we're different people and our genetics are a little bit different. The other thing that will come into play now are the newer strains of the virus that are hot topics in the news. We know that there are three strains that are being discussed most commonly. That's the United Kingdom strain, the South Africa strain, and the Brazil strain. And all those strains have been identified in the United States at this point. So those strains, even though they're newer in the United States, are being studied to determine if they tend to make people sicker than the strain or the strains that we had before. So far, it doesn't appear that way, but more to come on that with time.
Great, thank you. This is kind of, I don't know if you can answer this next question. Again, this is very informal discussion. I don't know if there's enough time, but I know that people have heard like the buzzwords like DNA, mRNA. If it's easy for you, in layman and lay people's terms, what's the science behind the vaccine? Why do they call it an mRNA? What does that mean? And we've had a question of, does that actually change my DNA?
That is, that's an excellent, excellent question. And I get asked that all the time. So I'm going to do my best here, Sal. So please tell me if I get too technical, just tell me to bring it back. All right.
I'll try. Thank you.
So I want to actually start off by talking about DNA. So I'll repeat it again, DNA. So not mRNA, DNA. DNA is what every single cell and every single one of us have. It is the master blueprint. It is the blueprint that leads us to be who we are, right? Now, obviously, there is a whole part of our environment that makes us who we are as well. But from a genetic standpoint, the DNA is truly the master blueprint. What that DNA does is it codes for every, like I said, every cell in our body, even though it's found in every cell. Every protein that's made by our body is coded by that DNA. But that DNA has to go through an intermediate step before it begins making a protein. So before it goes to the drawing board, the architect's drawing board, and it gives you that little kind of schematic, like I'm going to build a closet. This is how big the closet needs to be. This is how high it needs to be. This is where the door needs to go. Messenger RNA is sort of the schematic to that closet, if you will. So where the DNA is the master blueprint for the whole house, the schematic for the closet is the messenger RNA. So messenger RNA is different than DNA. And what then basically happens is that the messenger RNA then has a little workforce that comes around it and basically builds a closet. All right. So it's an architect, and then you have someone who actually is doing the work. So the carpenters and et cetera. What's important to know about messenger RNA is that it cannot integrate into your DNA. While DNA is used to create messenger RNA, it is not bidirectional. So it does not, you cannot take messenger RNA and make it DNA. So you cannot have, you cannot be injected with a vaccine that uses messenger RNA as basically the code to make you immune to, in this case, COVID-19. That messenger RNA will not code into DNA or become integrated into your DNA. The other thing that's really important about these vaccines, which the two messenger RNA vaccines that are on the market are the Pfizer, Pfizer, Pfizer.
Mm-hmm.
The second one is Moderna, Moderna. While they are different companies, the science and technology is basically the same. And I say that because that messenger RNA is degraded or disintegrated in our body fairly quickly. So both of these companies have allowed, and through proprietary measures, allow that messenger RNA to stick around long enough in order to do what it needs to do to create some immunity for our body. But it doesn't stick around for very long, and then it's disintegrated by the normal pathways that we have that get rid of messenger RNA. Was that too technical, or did that kind of make sense?
No, that was great. That you explained that perfectly. Thank you. And I know I've heard kind of doing research that it's going to change your DNA, so don't get it. So, but no, that was great. That really explained it. So thank you for clearing up the science about that. Since you did mention two of the vaccines that we know are out there, which is Pfizer and Moderna, we know those are two, and we've heard that Johnson & Johnson is potentially going to be approved for a one-dose vaccine. Can you talk a little bit about the different vaccines? Maybe what are the differences? Are they safe? And what if I have underlying health conditions? Do any of them impact underlying health conditions differently?
Yeah, so the Moderna and the Pfizer vaccine, I kind of lump in one group because they're that messenger RNA technology. Now, I think we're just to talk about one of the points that you made, I think that people are a little concerned about the messenger RNA vaccines because messenger RNA, while messenger RNA technology has been around for decades, so it's important to realize that, this is truly the first time that it's been used in a vaccine. And I think that that just concerns people, right? It's a new technology. But the principle of what it's doing is just like any other vaccine. It's trying to cause your body to have an immune response or to build an army of fighters in case you actually do see the infection. Now, the Moderna and the Pfizer vaccine, while they are different vaccines from different manufacturers, the science and technology are pretty much the same. So they both are messenger RNAs. They both do have a little bit of a nuance to them. So for instance, the Pfizer vaccine was studied. They're both what I call a 2-series vaccine series, meaning that you need a dose for Pfizer at day 1, and then you need a follow-up dose around day 21 with some leeway there for Pfizer. Moderna, same thing, dose on day 1, and then you need a follow-up vaccine, which is both the same amount, by the way, same amount for the first and the second dose, but for Moderna, you need that 28 days later, roughly. And there's leeway for both of those. So there is a little bit of difference between the timing of the first and the second dose, depending if you receive the Pfizer or you receive the Moderna. You are supposed to stay with the first vaccine that you receive. So if I receive the Pfizer for my first dose, I should try to receive a Pfizer for my second dose. And that's the recommendation right now. If I receive the Moderna for my first dose, I should receive a Moderna for my second dose. So it's important to know that. Now, the Centers for Disease Control does give some guidance, not necessarily recommendations, but guidance that if I accidentally received a Pfizer for my first one and received a Moderna for my second, or I received a Moderna for my first one and a Pfizer for my second, that my series is complete. But it is not recommended to do that. That's just incidentally if that does occur. So there is some guidance about if there is a different second dose than a first dose, although it is recommended you get the same brand first dose that you do for the second, and that's the recommendations. Now, if you have underlying health conditions, the vaccine itself is really not contraindicated for any specific health conditions at this moment. There is one kind of nuance to that people who have had a anaphylactic, which is a severe allergic reaction to any food, medication, therapy in the future, they may still receive this vaccine, but they should be monitored for at least half an hour after receiving it. They are finding out more and more about what may be causing the very, very few severe allergic reactions that have occurred with these vaccines. And just to put it in perspective, I think for Pfizer, there was 20 severe allergic reactions reported out of 1.9 million doses. So I'll repeat that again. There was 20 severe allergic reactions out of 1.9 million doses given. So it is very, very uncommon to have a severe reaction, but they still do recommend that if you've had a severe reaction in the past to any food or drug or other therapy, that you are monitored for about 30 minutes. So if you do have a health condition that you're unsure if you should get the vaccine, my normal recommendation is talk to the provider who's treating that health condition, just to talk you through that and decide if you really need to talk about the risks and the benefits.
And you actually answered one of the questions that someone had posted. And we know that distribution has been a problem. I know we're scurrying to get more vaccine manufactured, and people are concerned about, I got Moderna for my first dose, but now I can only go to a place that has Pfizer. So I think that was the question. I mean, that's been the big question is, can I get one and then the other? And it doesn't sound like that the CDC is recommending that it is a possibility or not a possibility.
They don't want you to do that, but what they know is going to happen is that someone's going to accidentally get, for instance, a first dose Pfizer and a Moderna second dose, or a Moderna first dose and a Pfizer second dose. And they're basically saying that if it happened, it happened. They don't want someone to restart the series, but they're not recommending. So if you had a Pfizer, you should seek out if you had a Pfizer first dose, you should seek out a Pfizer second dose. It's better to be late than to try to switch it up is what the recommendations are right now.
And you mentioned being late. So that was a concern from a number of people asking questions is we got our first dose and now I can't seem to get my second dose within that 18 to 21 day window. So what does that mean for people? Do they have to start over, or is there room for maybe 30 days, 35 days, 40 days, and will it still be effective?
So the primary recommendation is still to follow the emergency use authorization guidelines, which for Pfizer would be, and again, there's leeway. So I'm going to give a date of a certain amount of time, but if you don't get it on that exact date, that's okay. So for Pfizer, it's 21 days after your first dose. For Moderna, it's 28 days after your first dose. Ideally, that would be in a perfect world where you would receive your second dose is within that time frame, within a few days within that. But we also know that allocation has been a huge uplift, not really for the federal government and the state government as well. So the CDC does state that it is completely fine to receive either of those, either being the Pfizer and or the Moderna up to 42 days after your first dose. So that gives you up to 6 weeks to get that and try to secure a second dose. But they even go as far as to say that if you do not receive the vaccine within those 42 days, let's say you get it at day 60,
right?
And you have no, life happens. And you're not able to get it until day 60, or you're not able to find a dose until day 60, which hopefully is very, very rare. But if that does happen, your series is still complete and you do not have to restart your series again. So they do leave us with some guidance for that. So recommendation for Pfizer is 21 days. For Moderna, it's 28 days. If you're not able to receive it within that time, they do recommend you have it at least within the 42 days. But if you are beyond that 42 days, you just receive the vaccine and you do not have to restart the series again.
So let's say we have both, and again, we can't do fortune telling here just because we don't know what is happening. What do you think about, I get both of my shots, will we need boosters? How often? Is this going to be a yearly shot now, just like some of us go and get vaccinated for the flu? Do we know that this is going to be like a yearly thing, or do we need boosters? What's kind of what are people talking about, and what's your take on that?
So I don't know. And I don't think anybody knows right now, Sal. And I think if anyone tells you differently, they're just kind of making it up. I will tell you my concerns about why I think that it may require other doses of vaccine in the future. If the virus continues to change, or what we call mutate, into these other strains, there's strains that we had mentioned a few minutes ago, the question becomes, are the vaccines that are now available going to be just as effective as, as the strains mutate? And if there comes a point where the vaccines are not as effective, we're going to have to change our vaccines in order to stay, to stay on top of these mutated or these changing strains. I'll give you a prime example is the flu vaccine. So we get a flu vaccine, or it's at least recommended every year. And that's because the strains of the flu change within months. So we know that the flu that starts off being detected generally, in our area around October or November, will be a different strain than what the season ends with in March and April. And then we know that we're going to need a different vaccine for the upcoming season because the strains have changed. That could happen with COVID. It may not. It may not happen. And this does not appear to be a virus that has mutated significantly like the flu does. But obviously, we do know that it is mutating as well. So I'll answer that question, will we need a booster, as maybe.
So this kind of follows what you just said about the variants. This is a question from one of our participants this evening. We're beginning to hear more about the possibility that the current vaccines don't give adequate protection against variants, the South African variant in particular. Can you give an update on this? Thanks much. And I think you kind of gave us an update. Is there anything that you want to add to that question?
As more research comes out, I think we're going to know a little bit more. It appears that the vaccine, and I'm going to speak specifically to the Moderna and the Pfizer right now, because the Johnson & Johnson is being questioned, and I really don't know what the data is behind that right now. But for the Moderna and the Pfizer, they believe that it is providing adequate protection against the strains that we have already known about, plus the new strains that are there. But I will also tell you that much more research is going into this to determine if that's true or not. But the initial thought process is that the Moderna and the Pfizer vaccines do have effective protection against the 3 newer strains. But again, that could change an hour after we end this call and a new study comes out that says
Sure.
that it does not.
A question from another participant. Is it true that after getting the vaccine, even though it is preventing you from getting sick, you can still be a carrier and pass it on to someone else?
So that's extremely true, and that's a very valid point, and why we are still telling people, even those who are able to get the second dose of the Moderna or the Pfizer, that it is extremely important for them to still follow the 3 W's: wear a mask, wash your hands, and watch your distance. So just to elaborate on that for another minute, Sal, because I think this is extremely important, even though the Moderna and the Pfizer tout that they have a 94 to 96% efficacy rate. Let's talk about what that efficacy rate is. First of all, that means that it's not 100% effective.
Right.
So there's still going to be people who are going to get sick and are going to get ill with COVID despite having both of the vaccines. What we do know about the vaccines in real life at this point is that they are able to make us less severely ill than if we did not have the vaccines. So that 90 to 94, 96% means that it is helping a significant amount of people to becoming severely ill or hospitalized or dying if they do receive the vaccines, which is ultimately an amazing goal, right? Because we want people to become severely ill, hospitalized, or die because of this. But at the same time, you could still be a carrier. You could still be a carrier of this virus despite having both vaccines. So that's why life does not immediately go back to normal. So I could still, in my nasal passages, in my respiratory tract, I may not actually have any outside signs or symptoms that I am ill with COVID, but I could be talking to you and still be spreading, the virus. So it is possible, and a really important point to realize that the vaccine is effective for trying to keep us all around and not to keep us severely ill. But until more real-time data comes out, we do not know if it truly does significantly decrease the risk of being infectious, if that makes sense.
No, it does. And I have actually, I've got kind of 2 follow-up questions that fall within that same line. Are you ready to take a challenge on for 2 at the same time, or you just want to do 1 at a time?
Let's do it. Why not?
Okay. These I think are similar. How safe is it to interact intimately with someone who has had COVID and recovered? And then in the same kind of vein, can you comment on appropriate safety precautions 30 days after the second dose is complete for a social gathering of all vaccinated people?
So what I will say to answer the first one is that if someone is COVID-19 recovered, we believe that the majority of those people will have immunity for at least 90 days after they've recovered, meaning that the chance of them becoming reinfected is significantly low. probably less than 1-2% at most, and that's probably being very aggressive. So we think that people are extremely safe after they've recovered from COVID-19 for 90 days. So you have to take that with, with everything else. You should still make sure that you're wearing protection, and COVID or not, there's still a lot of other things out there that can make people sick. So
Sure.
please, do what you need to do to stay safe from that perspective. The second question about a social gathering with all vaccinated people, please, please, please keep in mind that you should not have a false sense of security, meaning
Right.
if you have 20 people, right, if you have, let's just make it easy from a math perspective. There's 100 people, right? There's 100 people at a party, at a social gathering. Even if everyone is vaccinated and someone or several of those people are asymptomatic carriers, there's a good chance that if that's a super spreader event, that 5 people are going to get sick and could be severely ill and hospitalized, or potentially even having bad outcomes. So it is not to the point where it is back to normal yet. Okay.
So thank you so much for taking the 2-question challenge quickly. This is a good question because we get a lot of this in our testing program at camp. We do a lot of syphilis testing, and we know that one of our screening questions is, have you ever had syphilis? And if people say yes, then we can't do a rapid test, because even though they don't have syphilis, they'll still come up positive for antibodies. So this is kind of COVID related question from one of our Facebook viewers. Will the COVID test be positive if you're a carrier with no symptoms? Are you suggesting carriers will always be carriers?
No, so carriers will not always be carriers, but there is a window of being a carrier. And I'm going to go down this rabbit hole a little bit, and you're going to need to bear with me for a second, because this is a pretty complicated question, although it comes from a place of trying not to be complicated. So there are different tests that are out there. And I think the first and most important thing is to discuss which test we're talking about. So if it is a PCR test that's looking for the genetics of the virus, someone who has become infected with the virus, and they have even gone through their infectious period of the 10 days, right after symptom onset for most of us, although for some of us it's 20 days, but for the 10 days, they could still test positive on that PCR test for several months after, because we're still able to detect little bits and pieces of non-live virus in the respiratory tract. That makes this very, very complicated, because think about it. If someone had no symptoms and they had no idea that they even had the virus, and you didn't catch them in that 10-day period where they're infectious, but let's say that they're going on a trip and they need to have a PCR test and it's here, and they swab them and they're positive because they still can detect the genetic material of the virus, even though they were sick back here. That test does not tell you when they were ill. So you normally have to match up the symptoms with that test. So that becomes a little complicated. Now, there is an antigen test that's available that normally has a shorter window period. So any of us who do HIV testing know about the window period, right? But generally has a shorter window period where there's a few days that you may not test positive, but then you also may not test. The other side of that window in this test is that you may test negative after about 7 or 8 days, because that antigen is really only there for about 3 to 8, maybe 3 to 10 days. So that antigen test may be a little bit helpful to kind of put you in a window period from that. And then the other type of test is an antibody test, which is a blood test. So, you get stuck for that, or a finger stick. And then from there, you can determine if you have been exposed and created antibodies towards the virus. And that could last for months and potentially years in certain individuals, and is less helpful to tell someone if they have active infection, meaning that 10-day period that they're actually infected, or months later and they were just exposed to the virus at some point along the way. So now that I've confused everyone, it's hard to answer that question because there are different tests and it depends on the test. So an antibody test, though, Sal, could technically test positive for months to years We don't know that yet because it hasn't been years that we've been doing that test. But it is potential for that to happen, like syphilis, which can also, you can test positive for months to years after, and then sometimes you can eventually test negative after it kind of burns out, years later.
Okay. So I'm going to challenge you again with two questions, almost similar. These are about maybe some procedures that we need after we've gotten a vaccine. So the first question is, I've just heard that women should not get a mammogram within 2 weeks of getting a COVID-19 vaccine. Is that true? And then the other question is, should I have any concern about how soon I receive an allergy desensitization vaccination after receiving the COVID Moderna vaccine? Are there any procedures that we shouldn't do after we've received vaccine?
None that I am aware of. My only comment to that is that we try to wait 2 weeks before and 2 weeks after for any other vaccines between a COVID vaccine. So let's say someone had a flu vaccine today, I would ask them to wait 2 weeks before they received any other vaccine, including the COVID vaccine. But there's no reason that someone should not be able to get a mammogram or a chest x-ray or another study just because they had the COVID vaccine. So I'm unaware of any reason or any recommendation that would suggest that. And then the second question that you had, you challenged me.
It was about if someone receives an allergy desensitization vaccination, will it impact if they've just gotten the Moderna vaccine?
Should not. I would always revert back to the allergist office who's performing that, but none to my understanding. That should not cause an issue.
So I have some logistical questions, but on our Facebook page, we're getting some questions now about side effects. And I hate even bringing this up because it's very rare, but we have people on Facebook that are concerned about side effects. And in some cases, we've heard stories that people have died as a result of getting the Pfizer vaccine. Have you heard anything about that? And why? What puts someone at a greater risk of maybe death from a vaccine or even very severe side effects from a vaccine?
So one part, because that's a multi-part question. So bear with me again for a second. And
Sure, thank you.
So anybody can have any type of, so anyone may have a severe allergic reaction or anaphylactic-like reaction to any medication, any treatment, any therapy, even things that you buy over the counter, right? So it's important to recognize that. There were some case reports when, I believe in England, when the Pfizer vaccine was approved, before it was approved here by a week and a half to 2 weeks, that there was a couple cases of people who did end up having a severe allergic reaction reported to the Pfizer vaccine, which made everyone very concerned. About the safety of the Pfizer vaccine. And I'll even extend that to the Moderna, but to the safety of the vaccines in general. So the CDC puts out something called the Morbidity and Mortality Weekly Report, MWR, which for any of us who have done HIV medicine or syphilis, we know that we also sometimes get those reports about rates and things of that nature. So a few weeks ago, they put out that there have been about 20 reported severe allergic reactions to the Pfizer vaccine out of approximately 1.9 million doses given. And I think that's so powerful to say, so I'm going to repeat that again. 20 cases of anaphylactic-like reaction out of 1.9 million doses given of this vaccine. So it's overall pretty safe statistically, which I think is important to know. But anybody can have a reaction to anything, unfortunately. And that's why if anyone has had a reaction, a severe allergic reaction to anything, we ask people to wait for half an hour. That's our practice. That's our best standard of practice, to wait at least half an hour before they leave the facility. We don't force people to stay. We don't
Right.
chase them down, but we do recommend and ask them to please stay with us for half an hour. There's a case report that's being investigated of actually a physician who ended up having one of the COVID vaccines in the United States, who did reportedly pass away several days to a week or two later. He ended up being identified as having a blood disorder that they are not sure if it was exacerbated by the vaccine or caused by the vaccine. And there has not been much more at this point to discuss. So I don't really have much information about that. But really for most of us, the concern would be that severe allergic reaction or potential anaphylactic reaction, which is actually believed to be lower in Moderna than it is on Pfizer. But I told you again, 20 cases in 1.8 to 1.9
Right.
doses is pretty low. So the odds are in all our favors.
Good. Thank you for clarifying that. I'm going to jump back a question because we talked about the mammogram and the allergy shot. So this is another question following those two questions. What medical procedures should be separated from a dose of COVID vaccine? For instance, should a patient get a shingles vaccine while waiting for a COVID vaccine?
So if someone feels that they are kind of on the brink of getting a COVID vaccine right now because of the application, right? I mean, because it's so strict and they're on a waiting list, and they're like, they may pull my lucky number today or this week. It's important to know that if you did receive a shingles vaccine or another vaccine within 14 days, it's going to be recommended that you wait for the 14 days before you get another vaccine, in this case, the COVID vaccine. So while shingles vaccine is very, very important, and I am not minimizing that, I do think that it's important to realize that if you think that you're coming up close to getting the vaccine, and the vaccine being the COVID vaccine at this point, just make sure that you try or attempt not to lose an opportunity because you get a shingles vaccine 2 days before and they're going to recommend you not get it. And then you kind of get bumped further down in the list. So that would be the only thing that I would think of.
Okay.
And I will also state that that's truly a decision between the person being vaccinated and really and their provider, right? I mean, about making the decision if they want to understand that 14-day limit is a guideline and not an absolute contraindication.
Thank you. So next question kind of is maybe a little fortune telling. So what factors will public health professionals consider when revising recommendations in the future? For example, consider an August wedding. Do you think that folks will know in early July what the precautions are and what will be necessary?
Maybe, that really goes to the larger theory of what we call herd immunity, with a large amount of us vaccinated or having natural immunity against COVID-19, that if we were to come in contact with it, it would not make us ill, and that we would not be able to spread COVID-19 to someone who could then become severely ill. So normally herd immunity starts around when about 60% of the community or the population, and that can be community being Sussex County, community being Delaware, community being the United States, however you want to define smaller to larger community. When about 60% of us have some type of immunity against an infection, then herd immunity starts to kind of tip in our favor.
Mm-hmm.
Doesn't hit until about 80% or higher. And what I mean by herd immunity is I like to use mumps as an example. So if everybody remembers back about 4 or 5 years ago, and I always mix it up. I think it's Disneyland, because that's the one in California, right?
Yep.
Disneyland. So Disneyland was linked to having an outbreak of kids that developed mumps, and it was in about 3 or 4 states. And it ended up being people who had their children had not received vaccination for mumps. And what normally happens is that if you have a room full of, let's say, 10 kids, and 9 of them are vaccinated against mumps and the vaccine works, that 10th kid is actually protected as long as, you know, he or she are hanging around the other 9 kids because they're immune to it. But when you start to change that ratio, so now you have 6 kids that are immune to mumps because of vaccine, but 4 are not, and then you end up getting around, you know, you have a chance of coming in contact with someone who's shedding the mumps virus, and then the other kids are sick. Now you have a little cluster outbreak of people with mumps, and that's what happened. So I say that the higher the number that people have immunity, and by people I mean our community, however small or large you want it to be, that we interact with, the greater the chance that even if we do come in contact with the infection, or even if we do become infected, if we all have immunity that's protecting us, even if I shed it to you, Saul, I mean, at that point, if you're not going to get sick, it's really not going to be that big of a deal. But if I have 2 or 3, 4 or 5 people that are in that room of 10 and they're not immune, and I'm shedding it and then they get sick, then it is a big.
So I guess that leads to our final question about the vaccine. And then after that, I'll have kind of maybe 2 or 3 logistical questions that you may be able to answer or not. So overall, what is the purpose of the vaccine? Is it to avoid getting the virus, or is it to minimize the effect of the virus, or both?
So ideally it would be both, right? I mean, that would be the best of both worlds. And some of these vaccines may end up doing that. And I think as we have more real-time data and more people become vaccinated, we'll know a little bit more about that information. But truly the vaccine is to help us from getting severely ill or hospitalized or dying. Now, obviously, it would be wonderful if that also prevented us from even becoming what I call an asymptomatic carrier for
Right.
even a little bit of time, or even if it shortens that time that I'm asymptomatic carrier, then I think it's doing what it needs to do. But for time being, until that data really comes out or supports that, you know, it's back to wearing a mask and washing our hands and watching our distance. I mean, and that's why we need to continue doing that.
And I know you don't have one of those 8 balls that you shake that come up with the answer. How long do you think we'll be living in this, having to wear masks and hand sanitizing and just avoiding social situations? Is that something that's even predictable at this point?
It's not. I can't say and look at you and say August 1st we're good, right? Unfortunately,
Sure.
for that wedding, I apologize. I think, and this is partly my professional opinion and my personal opinion. I think we're probably like this through the summer, or at least through a good portion of the summer. And then depending on how much I mean, we don't even have enough vaccine right now to vaccinate everybody who wants it. And I think it's going to take months to really achieve that, which is already going to be, you know, April, May, June. And then to get it just, you know, distributed and everything else taken care of. So I think we're like this probably for the summer. And depending on what happens with these new strains and how effective the vaccines are against them, it could be that could be a changer, I'll just say.
Okay.
So lots of factors that go
Sure.
into that, but I'm hoping, like everyone else, it's sooner than later.
Fingers crossed, knocking on my head here. 2 last logistical questions, okay? And this might, you may not have the answers because I know the systems are so elaborate, and we read the articles every day about what's available. And I've even heard of people hiring people to sit online to go to like RiteAid.com and Walgreens and Harris Teeter or wherever. Do we know if Delaware is reserving vaccine doses to administer the second one?
So, so what do we know? What do we know? We know that I'm going to answer this from Beebe Healthcare perspective, because I think that's where I have a little bit more control. And I am going to state that before I even answer it that way, I do want to talk about the chain of custody of vaccines. So all these vaccines are truly being allocated, allotted, controlled by the federal government. So what happens is that the state places an order, and then they get what they receive, what the federal government allots to them, right? And there's a lot of factors beyond my understanding of what that decision is made. Then the state ends up receiving an allotment of vaccine. And from there, Beebe Healthcare or Nanacoke or Bay Health or Christiana and all these other what we call pods, PODS pods that are able to vaccinate. So Westside and Walgreens and CVS and Rite Aid, they all end up receiving an allocation from the state. So it's a trickle down effect that happens. So while the state is diligently working with the federal government to maximize how much we receive, every other state is doing exactly the same thing to try to maximize it. So what my understanding that the state is doing is while they are working diligently to secure second doses, they also know that they can't drop the ball on first doses either.
Right.
It's publicly shown how many doses that they have, and there's delay to that too, by the way. I mean, there's delay from distribution, but it's important to realize that if they have given out 10,000 first doses and they have 10,000 doses on the shelf, that also is something that's probably a message that they just have to understand as well. So what we've done at Beebe is that we continue to secure second doses, and we've been successful with that. By managing our Millsboro COVID vaccine center, along with our waiting list or registry list, and the distribution that we have through our walk-in clinics. So the state of Delaware, my understanding is that they are working diligently to ensure second doses are secured. But there is a huge push from the federal government to make sure that first doses are not missed.
Okay, so the focus, excuse me, it sounds like the focus is on getting people their first dose, just to make sure that there's initial vaccinations, and then it's worrying about that second dose.
And it is a very fine line, right? It is a very fine line to really walk. And I think that the state is doing a decent job at this. I think that they're doing a good job to the best of their abilities, with not knowing how much vaccine they're going to receive on honestly on a weekly basis.
Right.
It's tough to plan when you just don't know. We're all being told that our allocation for vaccines, so the number of doses of vaccine that we all receive, will continue to improve. And I say that we're being told that is in not collectively just Beebe Healthcare. All of us in the state are being told that, and that's what the state is being told. So, fingers crossed that, that we're just doing what's right for everyone.
Okay, so these are like rapid fire questions because we're just running out of time. We just got 3 minutes left. So in your most easy answers for these two questions, how long are the vaccines protective after the second dose? And then can you just talk a little bit briefly about phase 1A? Does that include high blood pressure? And does that include someone who says that they may be obese? Do they need documentation to get 1A?
So to answer the first question, maximum immunity comes 7 to 14 days after your second dose of a Moderna or a Pfizer vaccine. So it's 7 to 14 days after your second dose that you will have optimal immunity. That doesn't mean that it immediately wanes away. So at day 15, you no longer have the same immunity you had at 14 days. It just means that you start to ramp up and kind of reach where you need to be. So that answers the first one. So just to talk briefly about how Delaware has handled its tiering or phase system, 1A includes healthcare workers, So someone who has direct or indirect contact with COVID-19 patients and or infectious material is listed as a healthcare worker, and long-term care residents are also 1A. And that's what comprises 1A, which is what the Advisory Committee on Immunization Practices from the CDC have also recommended. 1B, the Advisory Committee on Immunization Practices, so the CDC, recommends those who are 75 years of age or older, along with certain other groups. Those other groups would be frontline workers, essential frontline workers, and then others that fall within that tier. So I'm going to talk specifically of Delaware. So Delaware is deviated a little bit in 1B, B as in boy. It is 65 years of age or older. It is essential workers. It is production line workers, manufacturer workers, just because they work so closely next to each other that they, in our first surge, unfortunately, they had high levels of infection once someone in the line became infected. It also includes educators, and I'm sure I'm missing some groups, so I apologize if I am. So educators, including teachers, are included in that. The way that state of Delaware has rolled out 1B is that while those groups are included in 1B, their focus has been 65 years of age or older. And then I believe that the next group that will be focused on, while still continuing to focus on 1A, the 65 years or older, will be education. I think that will be the next kind of opening up. What I do think is important is that Delaware has just shy of about 1 million people that live in the state. So bear with me for just some simple math. So 1 million people live in the state of Delaware. When the state of Delaware opened up 1B, they opened up the eligibility for vaccine for 200,000 people at once. So wow. If you do 200,000 people eligible at once, in 2 doses with our current vaccines, that's 400,000 doses of vaccine needed if every single person wanted it out of that 200,000. In Delaware and Sussex County specifically, we have about 235 to 240,000 people who live here. And that's from 2019 census data. And about 30% of them are 65 or older, which puts us at about 70,000 people opened up in our county alone just to need vaccine, or at least eligible. And that doesn't include those who are healthcare workers. So that obviously is more than that. So it's important to realize that that's a lot of vaccine. And while not everybody wants that vaccine, it just is going to take patience, but everybody will have an opportunity to receive the vaccine. It's just going to take time in order to get there.
And the Delaware, I forget the website. I should have it. I should have had it handy. But for anyone looking for that information, the Delaware, if you just do Delaware vaccine COVID, it's an excellent website which gives you a visual graph of the different stages and where you would qualify. So that's one information source. And my final question to you, Dr. Bill, are there 1 or 2 sources of information that you would say, these are pretty safe and these are pretty reliable sources where we can get information? What do you recommend, maybe just website-ish instead of magazines or other journals? What's good for the layperson to Google something? Where would you send me?
So I would ask you to go to probably 2 or 3 websites, understanding that there may be a little bit of deviation in those, and that's okay. The first one would be the Division of Public Health. So Delaware.gov, I think it's /COVID/vaccine. I think that if I'm giving you the appropriate address, it has a nice timeline of where we are in the state of Delaware, which for most of us is where we reside and what's important. I think that also gives information for community members, but also provides information to me as a medical provider or as an institution of what I need to do. The next one would be the Centers for Disease Control and Prevention. They constantly are updating their website. It can be a little bit cumbersome to find what you're looking for if you're looking for something specific. But interestingly enough, eventually I have always found it. It just is sometimes hidden somewhere that I didn't know to look. And then for those who are looking at more of the recommendations beyond just the state of Delaware and then the United States and looking at the World Health Organization does a nice job. The World Health Organization and the Centers for Disease Control don't always put out the same recommendations. They generally are 95% parallel, but they will sometimes deviate because their purpose is different. CDC is the Center for Disease Control and Prevention for the United States, for what I assume all of us, not knowing who's going to look at your Facebook post, or the Facebook Live on February 8th, 2021. But then the World Health Organization is truly looking at the global community and trying to make recommendations from there. My one recommendation that I would say for those who are eligible and wanting to get the vaccine is I would not just put myself on one waiting list, because they are not interchangeable. They do not interface. If you put yourself on the state of Delaware waiting list, you're not going to end up on Beebe's waiting list. If you put yourself on Beebe's waiting list, you are not putting yourself on Walgreens waiting list. If you put yourself on Walgreens waiting list, you're not putting yourself on the state of Delaware. So unfortunately, there's no interface to put everyone on the same list, because it's all operationalized by different groups and different people. So I've been recommending for people to please put yourself on different lists. It's okay. It's okay. No harm, no foul, although I will admit that it does take a little bit more time to do multiple lists.
Well, great. Well, those were all our questions. So I really want to thank you again for such wonderful information this evening. I know that you're a busy person right now and you're doing lots of town halls. So thank you so much for taking time out for Camp Rehoboth's vaccine information webinar with you. We really appreciate it. And thank you so much, Dr. Bill. And thank you everyone out there who were able to participate this evening. And you please contact me, Salvatore at camprehoboth.com, if you have any other questions or concerns, or if we can do anything for you at Camp Rehoboth. But Dr. Bill, thank you so much. Thumbs up for you. We really appreciate it. Thank you for all the work you do in our community.
Thank you for everything that you guys do. And thank you for everyone. I hope I was not too boring and that people didn't sign off, and I tried to be a little bit exciting, Sal. Sorry.
All right, thank you. Have a good night.